to do is M1 macrophage specific imaging for arteriosclerosis using a nanoparticle biomarker. So what's the rationale for this intervention? The rationale, according to the findings of the Global Health Observatory, WHO, is that 48% of the non-communicable diseases are due to cardiovascular disease, and hence this is our disease of interest based on that rationale. Cardiovascular disease is because of arteriosclerosis, which is narrowing of arteries. Here is a diagram of an artery which shows severe narrowing as well as mild and moderate narrowing. Now the severe narrowing is usually treated, and it's the mild and the moderate narrowing that gets left untreated, and that is our target area because it's the mild and moderate narrowing that can cause a fatal and non-fatal heart attacks later on because of the macrophage burden, which is also correlated to the plaque instability. Hence, this is our target area of interest for imaging so that you can predict and prevent heart attacks, and also this is the target area for therapy later. And we're going to be using nanoparticle biomarkers so that they can be also exploited later for therapies, for dispensing of drugs required. So it's like a black hole technology.
Right, so how do we address this problem? Of course, with immunology. So you can see here that there's more M1 macrophages in the mild to moderate lesions. So what we're trying to find is to identify that vulnerable plaque, the inflamed plaque, by looking at the different phenotypes, specific phenotype for the M1 macrophages. For this case, I would just call it M1SP, so M1 specific surface protein. So what we're trying to do is design an antibody which has a FAB-based M1SP specific. So we'll take that part and then coat it onto a silicon shell nanoparticle with a radio label 18F core. So these nanoparticles will be injected via IV. Let it circulate to the blood, and it will specifically tag M1 macrophages, which may be onto the coronary arteries. The patient will be scanned via PE, PET, and CT. The PET will give us a phenotype identification, so it will glow onto the imaging, and the CT will give us an anatomical position. And when we overlay these two images, we will find the narrowing and which ones are more dangerous.
So what about money and market viability? We know from the European network that cardiovascular disease is estimated to cost about 196 billion euros per year to Europe. And of this, more than 50% is due to healthcare. So how are we going to low down this value? Well, first of all, there will be a reduction of hospital admissions due to heart attacks or strokes. Well, secondly, a reduction of care costs, such as social care costs. And moreover, there will be future development of targeted therapeutic delivery. Thanks.
So what M1 specific marker have you in mind?
In terms of potential ways of phenotype macrophage, M1 macrophage IV is the scavenger receptor for use of CD86, which is prosperous antigen presenting cell. But macrophage are predominant lung cell within the plaque, so it would be overwhelming sort of composition of the cellular infiltrate. You could use that as a specific marker for M1 macrophage.
And does current imaging techniques, CT angiogram and whatever, do they pick up the medium-sized ones that you're so worried about?
Yes, so currently, which is basically chronic disease, you use a common flow, but that doesn't necessarily correlate with plaque instability. So with the angiogram, you treat the most severe narrowing because that's impeding the most flow down the artery, but you will leave the mild one alone. But the mild ones are more metabolically active lesions, and those are ones which are more prone to eruption and cause heart attacks.
And the trouble being, of course, there's a morbidity associated
Well, currently fluorodeoxyglucose is used, but the problem there is that any metabolically active cell takes up FDG, and so you have sort of myocardial isomer in addition to the inflamed plaque. So you can't use that in coronary disease. You can use it to image carotid disease because the carotid artery is in isolation to any other metabolically active tissue.
I'm trying to understand how this technology actually alter the way that these patients go through treatment, as opposed to those who have been diagnosed by angiograms.
So it will fundamentally change the way that we treat patients from currently it's simpler to relieve symptoms rather than to improve prognosis. So when patients have stents, there is no sort of their mortality and morbidity isn't changed. It's just their quality of life is improved. Whereas by targeting the metabolically active plaque, you will then be able to reduce the mortality and morbidity of coronary disease. So potentially optimization therapy, we're actually treating the mild disease with a stent, which could be drug coated and a platform to deliver more focal treatment.
In terms of just preventing disease, why don't we just put everyone on statins with nothing much cheaper?
If we make everyone feel better, or doctors feel better, but currently optimal medical therapy only reduces the risk of mortality and morbidity by 25%. So it's ineffective, even optimal medical therapy.
Okay, thank you, Team 12.